Yeah, I don't really hear too much in there, at least on my setup.
I can't hear it at all.
Technology is amazing. All right.
All good.
There we are. So we're good, Chad?
Yep.
Alrighty. So the original conversation for Monday nights was around treatment planning, but we seem to take detours every now and then, mostly for good reason. But tonight, let's circle back and take a look at a treatment plan, one that I've executed, so we can take a look at, how I went about going to do the treatment plan, maybe what I would have done differently, what worked, what didn't work, so on and so forth. So this is the patient here. What I was thinking about doing is creating a problem list. So let's go through and identify some of the issues that we see with this photo alone.
Deep bite.
Deep bite, definitely. That's definitely what jumps out at me first.
Moderate recession.
Yep.
Abfraction as well.
Yeah, definitely add fractions, which I think is an important aspect of this particular treatment plan, which we'll talk about shortly.
Black triangle.
Yep. And that was definitely one of the patient's chief complaints, as we'll see, how we handled that. Isn't always straightforward.
Not a problem, but a consideration. Thick attached gingiva.
Definitely a consideration, yeah. Always looking at the biotype. Whether it's a problem or not, it's good to classify the patient's biotype. It makes a difference. Thin biotypes are harder to get good crown margins, getting those gingival margins to settle where they need to be. What else do we see?
Like
Uneven plane of occlusion.
Let's go with Chad first, just because I recognize his voice.
It's a little hard to see, but I imagine there's some crowding in the lower interior there.
Yep, definitely lower crowding. And what do we see here?
An uneven plane of occlusion.
Yeah, I was gonna wait on that, but I would definitely, whether you can see where the teeth come in contact or not, it's pretty evident here that the buccal corridor, or the gingival margins of the posterior teeth, are at a very different marginal level than here. So I would say, yeah, uneven plane of occlusion. How could we tell that this patient has a exaggerated curve of Spee, just from this photo alone?
Well, I mean, you can see off to the their right side in the shot how far their teeth dip down.
Yep. If we had to say what sagittal classification this patient has, what are they likely to be based on the deep bite? Two. Yeah, so deep bites tend to be class 2. As it turns out, this patient was not class 2. It had to do with this severity of the crowding. But in general, when you see deep bites, if there is no crowding, more often than not, there's a class 2 situation. And class 2 situations tend to have the anterior segment rising up, in which case the plane of occlusion would be off. So there are several clues here. What do we see here?
Mesially rotated first molars.
Sounding like an orthodontically trained general dentist if I ever heard one. Can you describe that a little bit more, Luke?
Yeah, when you guys, if you're looking, I know it's upside down for us, but if you're looking, rule of thumb, from the distal buccal cusp of the first maxillary molar, if you draw a line right through the distal buccal cusp and the mesial lingual cusp, it should go right to the canine. In this case, we're kind of leading the canine premolary on the one tooth, but the other one looks like it's a little more off.
When is that important?
That's more so important if you're trying to get rid of crowding and if you're trying to correct a class 2 classification.
Yeah.
Luke, I have a dumb question.
Hmm.
Are you talking about the canine on the same side or the opposite side?
The opposite side. No, that's not a dumb question. That's a good point. But yeah.
I was like, that seems like an extreme angle otherwise. Okay.
Yeah. Opposing canine, yeah.
Thank you.
Yeah, when I first learned about rotation of upper molars as a method to correct class 2s, it took a while for me to fully understand that, and I pumped Luke that you have that, you've developed that eye, because it is a way to treat class 2 cases orthodontically. In a nutshell, upper molars are rhomboid in shape. They're not square or rectangular. And because they're rhomboid, if you rotate them, you actually decrease the amount of arch space that they occupy, and that's a way to decrease arch length. So if anybody's interested, this is an important concept if you do Invisalign. If you want to correct overjets, rotating the upper first molars is a technique to help correct class 2 situations. So what else do we see?
Slight omega shape a little bit on the arch.
I would agree. Yeah, there's kind of this, I think she has an asymmetrical arch form, and then we'll talk a little bit more about that. But you can see how it kind of comes in and then flares out. So we classify arch forms in one of 3 different, maybe 4. So you have kind of the U-shaped arch. If it's a nice U, you have V-shaped if it's more of that horse appearance. Square-shaped arches, which are kind of uncommon, but they come up more. The buccal corridor is more in line, and then you have more of a right angle around the canine, and then you have the omega, where there's kind of this, just like the omega sign, the Greek sign omega, where it comes in and then flares out after. That's something I have personally. What else do we see? How about some obvious things about the cracks and fractures?
I was going to say
pretty
cracking
heavily
amalgams.
upstairs.
Yeah.
Big amalgams.
It's always interesting when we see a patient like this where their molars are cracked, they have lots of silver fillings or composite fillings, but their anterior teeth are not as karyogenically challenged. That's always an interesting observation. What I think of this is a biomechanical problem. This patient probably didn't have as much high caries risk as maybe the next person. How do we know that? Well, it's the molars that have all of the problems, and there's quite a bit of problems. In other words, the difference between issues in the front and issues in the back is quite substantial. So we'll come back to that because it's an important feature here. What about the anterior teeth, the position of the anterior teeth? 8 and 9, are they proclined?
They don't follow the arch form.
Yeah, they definitely don't follow the arch form. Are they retroclined or overly proclined?
Retropod.
Retroclined. So normally from this image here, you should see more of the palatal surface of these teeth. It'll become more evident when we look at the side shot. There's one other aspect in this photo that I think is worth talking about. It has to do with the palatal vault. I'm thinking that there was a tongue tie here, and that's why you have that omega arch, because the tongue did not spend much time during development and adolescence, did not spend much time in the roof of the mouth. When you see this kind of abrupt, kind of vertical to horizontal change in the palatal vault, more often than not, they have a high palatal vault, and they're more likely to be kind of constricted class 2 patients. So if you would just show me this arch and I just saw this line right here, I didn't see the teeth, I'd probably just say class 2. And understanding how craniofacial development occurs and how this relates to that is a very interesting concept. Maybe not a topic for tonight, but you can start to draw these conclusions because they are ultimately all related. There's our occlusal view of the lower teeth. So quite severe crowding. What else do we notice in this photo?
Fracture of the interiors and wear.
Yeah, which is quite significant considering she's somewhat class 2. You know, what kind of clues can that tell us? If she's not actually hitting edge to edge or anywhere close to edge on those lower interiors, why is there so much wear there?
Her tongue also looks very restricted.
Yeah, that's definitely what I see when I look at this. The tongue is very restricted. There's a book written by a dentist. It's called 6 Foot Tiger, 3 Foot Cage. That's what I think of when I see this. Essentially, the tongue doesn't have enough room. How does this happen? From a craniofacial development perspective, how does this happen?
I mean, it can either be because of a tongue tie, it can just be, basically lack of proper posture of the tongue. So,
yeah,
it can be for a number of reasons. But.
Yeah, oftentimes, thank you, Luke. A lot of times the tongue posture is inadequate because of the tongue tie. And a few of you guys were part of the tech string when I recently went to a airway study club a couple weeks ago. I'm now convinced more than ever that most, if not all, airway problems are tongue ties. And let's dive into that. Next Monday night, we have the ENT is going to be doing our NECADE session. So we're going to go through a CAT scan together with an ENT, kind of talking about different things. And I'd love to get her take on tongue ties. But it's pretty evident that this tongue didn't posture very well. These teeth obviously did not erupt the way that they should. Obviously, this guy is severely out of place. You know, Luke had once brought up a good point during one of our early NECADE treatment planning sessions that when you see this much of the facial surface of a lower posterior tooth on the occlusal view, this is lingually tipped. In a well-developed arch, you should see as much of the buccal surface as you do the lingual surface. Luke, you got that understanding from your ortho training. Is there anything else? You know, is that something you try to do orthodontically when you are putting brackets on, trying to upright teeth?
Yeah, definitely. It's something I'm usually checking for every time. Especially, something else that's kind of neat. If you guys are ever looking, if you happen to measure, if you're measuring, we always get stuck measuring like lingual on the palatal of the maxillary first molars. But another good measurement to go by is if you're looking at the buccal measurement of the maxillary first molars and the buccal measurement of the lower first molars. There should be a 4 millimeter difference there, upper to lower. And if it's off, you're like, you have to figure, that gives you an indication of like, where you're off by and how much or what needs to change.
Very interesting. Are you saying the gingival margin or the cusp tip?
It'd be the most buccal portion of it. So usually I go by gingival margin. Whatever is the most buccal, but yeah.
Yep. Very interesting. So that would give you a transverse discrepancy. If you were not 4 millimeters, if you were less, that's a more likely to be edge-to-edge posterior bite. Whereas if it's bigger, you're more likely to have a exaggerated posterior overjet.
Yeah. And you can also use it if you're trying to, say, expand somebody. And let's say you want to know their lower looks okay. You can upright their lowers, but how far do you really have to expand them to get the alignment, roughly right? That you could just measure the bottom and say, okay, the top is here. This is where the buckles have to be. And then your lingual side will obviously line up to where it needs to go.
Yeah. Luke, can you explain the difference between a conventional method of expanding the upper arch versus the lower? Like, what do we do differently?
I haven't had any good luck expanding the lowers. On the upper, we obviously use our removable expanders. And for you guys, if you're not familiar with that, we've been using It's come up in some other sessions, I think, but we use removable palate expanders for adults, and basically you can do it. It's different because you're not cementing an expander and it's removable, and we can talk more about it a different time, and Dr. Roy can really go into it, I'm sure, with you guys, because he's the one who brought me into it initially. But essentially, getting some expansion, taking the expander out is the magic, if you will, that helps with making it happen. And but the lower, we haven't had so much of a. I haven't had too much luck. I've tried it twice. People don't tolerate it well, but the lower, you're really able to upright teeth and stand them up and get them where they need to be. But if someone's lower is really restricted, short of doing surgery, I think at least at this point in time, I'm not sure what else we can do to expand someone's lower truly and get them to match. So you're kind of, in some cases, it seems like, at least right now, unless we find something else for an answer, we're kind of dictating our arch width by the lower to a degree, because we can't make it ridiculous. Unless you're gonna start doing crowns and everything, you might be able to have a little more play.
Yeah, well said. Uprighting the lower posterior teeth is really the method for expansion. There are, like Luke said, there's lower adult mandibular expanders that supposedly work, but like you said, the patients don't tolerate them that well. It's hard enough to tolerate the upper, but that can be managed. Really, when you upright these lower posterior teeth, you get a lot of expansion. A lot of times the case is actually set up that the lower posterior teeth uprighting is what's needed, not necessarily expansion of the mandible. A good way to tell is look at how much bone and gingiva there is here. So you can imagine when you upright these, there's still a lot of room for them to go. Basically, the mandible is plenty wide enough to support that movement.
Sorry to hold up. What's coming to mind for me, and I have limited ortho knowledge, are CADs and coils. Are those modalities for expanding, or is that for something else?
Yeah. It's a great question. I'll let Luke talk about coils. I think that's more his cup of tea. TADs are essentially devices used to anchor a multitude of movements within orthodontics. You can use them for all kinds of different things. They shine in certain areas where clear aligner therapy doesn't shine. So we're starting to use a lot more TADs with clear aligner therapy, such as Invisalign, where patients don't want metal brackets. But even with metal brackets, sometimes you just don't have the force vectors required to do certain movements, and TADs give you that force vector. So that's kind of how I think of TADs, is an anchorage in a vector of force that you couldn't get otherwise. Coils, Luke, what's your thought on coils?
I mean, I have never used coils to expand. Like, coils are great. So if you guys ever do end up doing some ortho stuff, let's talk a little bit. And it would be awesome if you really do want to do it, to take that courses I'm taking. But coils for expansion, not so much. You have to put someone in a stainless steel wire, because you can't put them in nide tie. Never put any working force on a nide tie wire. You won't be good. But you throw them in stainless steel. You can put coils on. It's great if you're trying to really grab onto or move a tooth bodily. Whether you're trying to move it, mesial or distal. I haven't seen too many people try to do too much expansion, but it's great, again, if you're trying to extrude. You hook up a TAD, and then you hook up that, you could hook a coil up to a tooth and a TAD, and then that won't really do what you're trying to do, or vice versa. If you're trying to go the other way, I guess, but I don't know if that helps at all.
Yeah, auxiliary devices to get the job done is really the art, the science and the art of ortho. Maybe we have a conversation about TADs. I have several cool cases going on right now. They'll be cool if they end up the way that I think they should end up, but I love the idea of using TADs for certain things. So here we have the buccal corridor shot. Looking at how severely lingually tipped these teeth are only emphasizes the fact that you're more likely to have abfractions and recession. So it's kind of interesting that we have very minor recession here, and that tooth is not in lateral excursive interferences. In other words, when this patient's mandible goes to the left, this is the tooth that takes all the force, definitely the lateral more than it probably ever wanted. But meanwhile, this first premolar doesn't take much of the force laterally, therefore it hasn't exhibited much recession or effractions. So I always want to look at where am I seeing this periodontal breakdown and effraction, and what's happening biomechanically as a result. What this tells me is that the patient's trapped or locked in. The lower mandible and the teeth within the mandible are sitting distal or more towards the midline than they want. So the mandible's in essence trapped. And when we see entrapment, we see all kinds of things. We see fractured back teeth, we see recession and effractions, we see or feel fremitus of the anterior teeth. This is why we expand. This is why we try to get patients more freedom. We try to get them long-centric, a term used from the Pankey and Dawson world. Essentially, we're just letting the mandible find its sweet spot. This arch did not develop very well, so this patient has had an entire lifetime of a retracted mandible. And because of that retraction, the muscles have never been happy. And because they're not happy, they take out their stress on the teeth that do come into contact. Does anybody have any questions about entrapment? Because this photo articulates it very well. And it's such an important concept. It's not atypical to have one side more pronounced than the other. You can see here, although we have severe lingual tipping of the teeth, just not as bad. Not as bad as the other side. We have a late attendee. All right. So here's the left and right sides. Looking at them in comparison, you can see that there's just a lot more problems on one side versus the other. Typically, this results as the craniofacial development occurs within the patient, often due to postural issues. In other words, the tongue might be okay going to one side, but not the other. And then you get these asymmetries that result. So let's add to the problem list. Is there anything that we can see here in the patient's portrait shot? So looking at her lip competency and how her lips come together, does that look like a incompetent lip union is the term that's used? In other words, does it look like she has a reverse smile to her lips at this position? And if so, what might that mean? Chad, are we still here?
Yeah.
All right. So sometimes in this photo, when you see that reverse smile architecture when the lips are closed, might mean that their vertical dimension is compromised. So if we go back to this photo here, if we can imagine in our mind's eye that if we uprighted these teeth and we uprighted these teeth, that the vertical dimension of the entire jaw would be open more. So it's not atypical when we see class 2 patients or patients with these tilted posterior teeth that they have an inadequate vertical dimension. I don't want to say loss of vertical dimension because that's not necessarily what's happening with this patient. But the reality is, as we upright posterior teeth, we often increase this appearance here to something that looks less aged and more beautiful. So keep an eye out for this. This particular photo is very helpful in us understanding, is this a patient that should have their vertical dimension opened? Well, if we believe that form follows function or aesthetics follow function, I would say she'd probably function better if we opened her up because the aesthetics don't look right. So here we are post-orthodontics. I used Invisalign for this. Quite amazing how clear aligner therapy can unravel a case. I don't want to say open up the bite, but you can see how much of the deep bite we resolved through Invisalign alone. This is not a difficult Invisalign case. It looks crazy, but this patient was very compliant. And uprighting and unraveling crowded teeth is not very difficult for Invisalign. When we talk about intruding teeth or extruding teeth, that's where clear aligner therapy doesn't do as well as metal bracket orthodontics. So when I saw this case, to me this was very predictable. Obviously the patient had to wear the trays very consistently, which she obviously did. This guy didn't concern me at all because I knew based on the ClinCheck that there was enough arch form for these teeth to resolve. Any thoughts
How
or
long was the
questions?
treatment time?
18 months. Which is,
Hey, Doc.
yeah.
I was gonna say I got some. I mean, this I don't know if this is helpful for you or anybody. I got a couple like measurement things when you're doing these, which is kind of like nifty to keep in mind if you're uprighting or moving people's teeth.
Yep.
You want me to share them? I got.
Yeah.
It's like for every 2.5 degrees of torque on the incisors, you gain 1 millimeter per side. So that's one thing. So every 2.5 degrees of torque on incisors, you gain 1 millimeter per side.
Yep.
Another thing, for every 1 millimeter, the mandible rotates down and goes back. You get 1 millimeter. You get 1 more millimeter vertical, and then the same thing going forward and up. And then for every millimeter of uprighting, you gain 0.6 millimeters of arch length. So if you guys have a discrepancy you're trying to overcome, every millimeter you upright the teeth, you're going to gain 0.6 millimeters of arch length.
Yeah. You know, it's amazing what happens to the mandible or the jaw relations when you move teeth. You know, I think that's the take-home message there, is that there's a lot of influences when we're moving the teeth with how the jaw functions. And if we can influence how the jaw functions, we can open up the airway. We can give the muscles a more relaxed tonality. We can give the face a more beautiful appearance, all from moving teeth. You know, we often think the teeth are what we're trying to fix. In reality, we're trying to fix the system the teeth would live within. Anything else here with the orthodontics? So I don't have a whole lot of photos of the crown lengthening, but I did want to talk about why I crown lengthened. This goes back to Elijah's comment about the black triangle. So this was a 10-day post-op after I did the crown lengthening. Here is the pre-op, and what I tried to do was draw a line connecting the tips of the canines. So if we remember from anatomy and morphology, the central should be on that same line. Granted, we're only off by maybe 1.5 millimeters here. The reality is, the incisal edge position often dictates the starting point of a case. One of the most beautiful things that Frank Spear brought to the profession was the very obvious fact that when we do denture setups with wax rims, we're essentially asking the question, where is the incisal edge of the future denture going to go in relation to the lip? We don't do that with teeth very often. Well, I did that assessment with the patient, and I knew that the incisal edge was too long in her face. So I really had to go up. So I knew I had to do some crown lengthening. She asked for a perfect outcome and didn't mind the cost and surgeries associated with the case. But in reality, it was this black triangle that really led me to wanting to do crown lengthening. We'll look at that in a second. So here's the post-op after the crowns were delivered. So after the crown lengthening has healed. Definitely a discrepancy here. On prep day, I should have been more cognizant of the fact that these were not at the same level. Hindsight's 2020. When you have a big case like this, there's so many data points you're looking at, it's easy to overlook the obvious. Patient was fine with it. I offered to redo both these crowns with a little bit of a gingivectomy here. Because I did crown lengthening, I know the bone is far enough away. But in reality, this particular incisal edge position was much more favorable for this particular patient's lip. So we can see here drawing a line from the canine to the canine. I was able to at least bring up number 8 to the same level. So I was able to crown lengthen at least 1.5 to 2 millimeters. Looking at it a different way, I actually got quite a bit of crown lengthening, but I was also able to close the black triangle because I was able to bring the margin much higher up, which gave me more running room to close this space here. So if we look at these two lines here, what I did is I put a line at the bottom of the papilla. I did not do not papilla, but frenum. I did not do a frenectomy here. In hindsight, maybe I should have. But I put the line at the bottom here and the bottom here. Look at where the teeth are in relation to the line here versus here. So one can surmise that this distance here was the amount that I crown lengthened. Any thoughts or questions about this? Had I not done crown lengthening, this would not have been as aesthetic because the contact points would have been much lower down on the tooth and it would have been harder to get rid of that black triangle. So there's the final case. Again, these margins, not super happy about. Offered the patient to redo it. She never shows them. She was not interested in continuing. At this point, she was ready to be done. It's been a long road for her. But in hindsight, when we prep the anterior teeth, we tend to just follow the gingival architecture. We really should be following symmetries. And if we need to break out a laser, remove some tissue, we should be able to do that. Interestingly enough...
Hey, Nick, go ahead. Sorry.
No, go
you have
for
a
it.
question about the crown lengthening. Did you do crown lengthening at just at the CEJ, or did you also include the papillar crestal bone?
Yeah, good question. So interproximally, I brought it in. So I definitely did interdental, the interdental bone. Anytime you do crown lengthening, you have to ask the question, what are you trying to do? So the first reason why we do crown lengthening is to get more ferrule, in which case you're going to go all the way around the tooth. If you're doing just aesthetic crown lengthening and you're just trying to get longer teeth and you don't have a black triangle scenario, you can get away by just doing facial crown lengthening. But if there is a interdental defect of any kind, then you definitely want to carry that interproximally and have it flow with positive bony architecture as you wrap around the palate. So the answer is yes, I did some interproximally.
Thanks.
Yep. So this guy here, obviously this tooth was very lingual when we did the orthodontics. So the root itself was not necessarily as close to the facial contours of the bone and soft tissue. As a result, it looked shorter. I could have crown lengthened that, made it look longer. Patient wasn't interested in doing that because she would never show it. But I think understanding why this tooth is shorter is a very important point. Does this make sense why this tooth looks shorter as is? Obviously, I prepped it to the gingival margin, and that's why it looks shorter, at least on the restored aspect. But where this root sits in the alveolar bone was much more lingual. And even though we brought it buccal, we only brought the crown buccal. The root is actually still sitting pretty far palatal or lingual. Anybody have any questions about that? Take a look at lower anteriors and just look at the different heights and where they live in the arch form. There's a lot of conclusions that we can draw when we start to understand these more subtle things that show up in our patients' mouths. So there's the upper arch. Lower arch. You know, she was a little class 2, so the size of the incisors is rather thick. That is a prosthetic solution to solving class 2 situations. But facially, this looked really good. This particular image, I haven't done it yet, but the American Academy of Cosmetic Dentistry if you do full mouth rehab cases, and I think you have to do one and present it to them, they ask for canine guidance. So this was an image intended to show just that. The point is that canine guidance protects our back teeth. If we go back to that photo where the patient was really trapped in, the fact that the canine guidance was so severely entrapped put a lot of stress on the back teeth, and I think that's why she had a lot of posterior tooth issues. So as we start to look at patients, when we see there's a subset of patients that have really low caries risk, but they have a lot of posterior cracks and a lot of posterior tooth issues, in general, they have some sort of entrapment issue. That's amazing. Once you start to connect those dots, you start to say to the patient, you don't need crowns in your back teeth, you need ortho, or you need expansion, or you need something along those lines. So you're trying to get to the root of the problem rather than just fixing the result of the problem. All right, so that's pretty much it there. I'll leave this here. Any thoughts or questions? Anybody want to take a stab at what material this is?
I have a question.
Go ahead, Jed.
How did you go about the prepping and temping, and did you do anything in phases? Did you do it all at once?
Yeah, I thought about including the execution. Since we have time, maybe we do talk about it. First and foremost, there are labs that do a really good job at helping us with that. I was not using a lab that, I think the aesthetics here are good. There's lots of things I would pick apart here. They're rather opacious. This canine, for example, is far too opaque for me. But when it comes to workflows of full mouth cases, Arrowhead Dental Lab is, to me, the best I've ever found. I looked for years to try to find a lab that could handle helping a general dentist walk through these cases with a high degree of predictability and not have $500 unit crowns. You can imagine how expensive a case like this would be if you're paying $500 a unit. Arrowhead's up there, but it's worth every penny. So in general, how I did this case is very different than how I do it now. So I think it's more important that I just share how I would do it now. In general, you get the wax up at the vertical that you want, obviously after the ortho. Getting that bite relation during the diagnostic records is the most important step, because the wax up is going to be made, and if the wax up is not made at a vertical dimension, and when we say vertical dimension, we're not only talking about kind of vertical dimension, we're talking about anterior posterior dimension. So whenever I think of jaw position, I picture the incisal edges of the lower incisors and their relationship to the upper incisors. So if we picture in our mind's eye that there's a relationship between those 2 points in space, where we put them in relation to each other is jaw relations. We're relating the lower jaw to the upper jaw. How do we normally do it? We just keep the patient where they are. That's called centric occlusion, or MIP. Single tooth dentistry is done in those situations. But the moment we start moving teeth, we're changing that relationship. So we should have some intention in where we're bringing that lower incisal edge point, just to make it more clear. How about we'll just call it this embrasure in relation to this embrasure. There's a vertical component, up and down, incisal gingivally, and then there's an anterior posterior component. We can also call that sagittal. So there's an XY axis component that we're trying to account for when we're trying to decide where we want to put that. And this is the topic of very advanced training at Spear, Coyce, Pankey, so on and so forth. The point is that when you're doing this kind of dentistry, you should have some sort of idea about the ideal, where you're trying to put that patient. So jaw relation record being the first thing, so that you can have a wax up made. And then the first appointment, I'll do the upper teeth. I'll prep the upper teeth and then do snow caps on the lower. Snow caps are essentially transferring the lower wax up at that ideal vertical position that you established at the previous appointment, so that the patient leaves with a good bite. They'll leave with upper temporaries and lower snow caps. Next appointment, I'll deliver the uppers, and then prep the lowers, temporize the lowers, and then the final appointment, deliver the lowers. That's under ideal conditions. This case went pretty well because there were no soft tissue issues. The patient didn't have bleeding gums. There were no implants to account for. It was a relatively straightforward prosthetic rehab, even though it was a full mouth rehab. So that's it in a nutshell, Chad. I'm not sure if I answered your question.
Can I ask 2 questions on that?
Yeah. Go ahead.
One is when you do the snow caps, I forget if you've touched on this before. Are the teeth contacting, like you can floss through them, or just temporarily you can't? Like, are you trying to?
Correct. Yeah. I mean, in theory, you could do snow caps where you individually cap the teeth.
Just seems like it would take a lot more time.
It takes a long time. Yeah.
So what are you just telling them to like water pick around them until you get the teeth temped?
Yep.
Okay.
Yeah, and I'll be honest, the water pick in situations like that does a really good job in a patient with decent salivary output.
Sorry, my son is talking.
No problem.
And then the other question is, when you choose to temp a whole arch, are you trying to, like, are you linking like so many crowns together? Like, do you have a specific, I mean, if they're short, it's different, but if you don't have to for strength, how do you choose to connect them or not?
Yeah, I used to do an entire arch. That's just the way I was taught once upon a time. Now I do it in 3 segments, so I'll do canine or behind the canine, canine to canine, and then premolar back. So 3 segments tends to do better because there's always going to be some flexure. As the patient is biting on one side, you're going to have indirect forces on the opposite side. By having spaces between the teeth, you have almost like a stress breaker effect. We have a lot less debonds as a result of that.
Do you find that you have a lot of patients when you do like one whole arch and you snow cap the bottom? Do you have to ever go and like adjust occlusion to get them comfortable in that before you prep the next arch? Or is it usually?
Yeah, I mean, that's a great question. And I think that's an opportunity to get the bite right, for sure.
And you'd want to get the bite right, obviously, before you prep the next arch, ideally.
Yeah, I mean, we're definitely getting rather advanced, and I love this topic. No, I love it. I don't think I can answer that question without...
It's like case dependent.
There's the ideal case execution of a full mouth case like this. In general, it's amazing how accurate the bite is if everything goes well. The problem is if it doesn't go well, what do you do? And that's where it gets kind of complicated because you don't want to just adjust until they start hitting everywhere, because it's possible that what you're adjusting was right and the other side is actually deficient. So oftentimes what we'll do is we'll measure a distance between the CEJ of the upper teeth to the CEJ of the lower teeth and say, are we at the vertical that we had anticipated with the wax up? And if we are, and they're hitting on one side, not the other, it's very possible that there was some deficient material on one side. So it becomes difficult, but what I will say is when you take your bite records, the temporaries or the snow caps on the lower should be good. So the way I normally do it is I'll deliver the uppers, do the snow caps on the lower. We'll T-scan the patient so that their occlusion is good. For those of you who don't know what a T-scan is, it's a computer-assisted occlusal equilibration technology. It tells you a lot of information about how the teeth come together, more so than just articulating paper alone. So I'll equilibrate them and then let them live in that for a period of time. Now, oftentimes what I'll do is I'll prep the lower teeth. So upper teeth get delivered, I prep the lower teeth, I'll leave canine to canine, and then the posterior teeth are prepped. I'll take a bite between those, so both sides. Now what's holding their vertical dimension open at that point is the front teeth with the snow caps. Now I have posterior bites that are keeping that vertical open. I'll then prep the rest of the lower teeth, and then I take another bite because the vertical is being maintained by the bite out back. And then I have a full bite at that vertical dimension of where the snow caps were. And that was after T-scanning. And to this date, when I do it that way, I have not had a problem with the occlusion because it's dialed in the temporary, so to say. And then I'm maintaining the vertical by prepping select teeth, capturing the bite, then selecting, prepping more teeth, and then getting the full bite. Does that make sense?
Question: are you, since you're prepping it in, is it sextants then that you're prepping?
Yeah. Yep.
Do you have to alter your provisional stent in order to make it fit?
Alter the provisional stent to get it to fit. So the stents are, I think I'm following it. I think it's a good question. You know, how do the stents fit? The stents from Arrowhead actually rely a lot on the soft tissue architecture to fit. So they're not relying on the teeth. You know, if you're doing full mouth dentistry, you often have, you lose all of your reference points. You know, what we do when we do a single tooth, you know, we take an impression of a quadrant, and then we prep a tooth, and it seats back on, and it fits because of the teeth that are nearby. But with provisional stents for full arch dentistry, you really have to have a lot of soft tissue information in order to make sure that it seats where you want it to seat.
Okay, cool. Another question: so say you don't have, you said it's a T-scan. Is that what you called the software?
Yep.
If you don't have a T-scan, can you rely upon like the traditional method of identifying VDR with like a popsicle stick and a Lucia jig, or some other method of capturing CR? I guess those are two different things, but basically trying to find VDR with a popsicle stick or something more traditional.
Yeah, I mean, the T-scan didn't exist for many years. What I like about the T-scan, articulating paper gives you a location, but articulating paper and all of these other tools that you just mentioned don't tell you timing. In other words, if you have a blue mark here and a blue mark here, which one hit first? And which one hit with more intensity? So some of the papers that came out of the T-scan world made the very clear point that the size of a dot has nothing to do with the amount of force that the tooth is receiving during that occlusal mark, which is so hard to conceptualize, but it's been proven time and time again. The size of a dot does not tell you the force on the teeth. T-scan tells you the force on the teeth. So can we use some of those other tools to dial things in? You know, a Lucia jig is a device that's used to get patient-centric relation. I would like a Lucia jig during the diagnostic records to get the diagnostic. If my goal was to get the patient in centric relation, I would do it at that point in time. But if I was really trying to get the patient-centric relation, I might actually make them an anterior deprogrammer and have them wear that for 3 to 6 weeks, whatever the time frame is, depending upon the severity of the condition, sometimes up to 12 weeks, to deprogram the muscles to get you into centric relation. Then you take your bite record, and at that point, the Lucia jig has done its job, or the deprogrammer has done its job. The Coist deprogrammer being a very good tool for that. But once you've done that, really the patient should be rather reproducible when you get to the snow cap stage. I mean, you should put the snow caps on, and they should just tap, 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 and they're right there. Because you've taken out all of the neuronal patterning in the muscles that cause aberrant jaw functioning. And that's what deprogramming is. You're deprogramming muscles that are behaving badly, is kind of how I like to think of it. And when you get the muscles to behave well, they seat better. The condyle seats better.
And that aberrant jaw functioning, does that correlate to like a CR shift?
Yeah. Yes and no. So the CR-CO shift, CR being centric relation, centric relation. Centric relation is a condyle position. Centric occlusion. But before I say what I'm going to say, the term you use, I understand what you're saying, and it is a very common term. But there are a lot of people out there who say, well, the CR-CO shift, those are two different terms. CR describes a condyle position, whereas CO describes the position of the teeth when you're in centric relation. I think the more accurate term might be, I say more accurate term because that term is what's used. But I think it's important to know when we talk about centric relation, we're talking about where the teeth are at that point. So CO being where the teeth are when the jaw is in centric relation. I think the more accurate term is the CO-MIP shift. You know, it's that difference between where the teeth go normally under, you know, not having a dentist influence the mandible position to centric occlusion where the teeth come together when the condyle is seated. So that discrepancy that's there, and most people have that discrepancy. I wouldn't call that aberrant. From a functional perspective, in other words, the muscles might tolerate that just fine. There's lots of people that have that and their muscles are okay. Aberrant, I'm talking more about neuromuscular disharmony where the muscles that control the mandible are very much unhappy. You know, if you ever look at a patient and you see their jaw tremoring or their tongue tremoring, that's their neuronal patterning in a very aberrant state. And I think that's more what I was referring to when I use that term.
All right, thanks for explaining that.
Yeah. You know, as we can tell, this stuff gets complex, and it's hard to describe it from this photo alone. But these are all important concepts, whether we're doing full mouth dentistry or single tooth dentistry. And there's so many examples that we've talked about on these sessions about when a point of initial contact is altered just from a single restoration. A single occlusal filling can throw off the whole system. Happens all the time. You know, we'll do a crown on number 19, and then a week later the patient comes back and they broke number 5. And they're like, I haven't had any teeth problems, but you worked on 19 and somehow you must have broke the tooth on the other side of the mouth. In reality, we did. Is it our fault? Not necessarily. There's ways to avoid that. There's ways to know whether that might happen. You know, but these are all concepts that we need to understand that there's a system that we're working in. And it's not just single tooth issues. So on that note, this material was zirconia. This was my first full mouth rehab with zirconia. I used to do a lot of EMAX in the anterior. I just felt this patient really could benefit from having higher strength. EMAX is strong, but then again, with the right patient or the wrong patient, EMAX can break. Obviously, with a well-balanced occlusion and a night guard, EMAX shouldn't break. So I don't want to say it's a weak material. But this was the first stab that I took at porcelain fused to zirconia, so PFZ. So number 7 through 10 and 24 through 25. It's a zirconia ingot, so essentially the core, which used to be metal for PFM, is zirconia. And then the lab technician brought in some feldspathic porcelain on the incisal edges to give it that more translucent look. And then everything posterior to that was monochromatic zirconia. So all in all, patient was very happy. You know, it was a pretty cool case to execute because it brought in a lot of the different disciplines. But it's a good example of what happens when the patient's jaw is entrapped. You know, and I've shown this case to a few other groups, and I often get the, why the heck would you prep some of those teeth? Anybody want to take a stab at that? I think that's a good concept to end on. Why, when we do full mouth rehabs, do we prep perfectly good teeth?
Sacrifice good enamel for a greater cause.
Yes. What's that? What is that greater cause?
Occlusion.
Occlusion.
Yes.
That's it. You know, this wasn't working, you know, for a multitude of reasons. So although one can definitely argue that that tooth didn't need a crown from an individual structural perspective, there was no way I was going to create occlusal harmony by only crowning some teeth. Some cases you can get away with it. Some cases you can select, certain teeth within the arch to crown. But if you want to get ideal occlusion and get something that looks like this, you really have to crown all the teeth. Could you do orthodontic extrusion to get those teeth to come out? Absolutely. But this patient was looking for something more aesthetic and more functional. It didn't require that level of care. And I'll go to bed tonight knowing that tooth is as good with that zirconia covering, knowing I use glass ionomer cement. That's not going anywhere. That's as good as, if not better than the enamel that she had on there before. So, on that note, I'm going to grab a pizza at Portland Pie before I head to Bar Harbor. Hey, the Regans are here. Didn't even notice. Anybody have any last minute items they want to throw in?
Dr. Roy, how much, when we have a full mouth case that we want to do, what's the workflow for working it out with you?
I don't understand the question.
Let's say it's my first year out and I want to do a full mouth case. What do I do?
Depends on a lot of factors.
At our practice, though, we start with diagnostics. And then, I know when I started, generally you and I sat down and went through every case together for like almost 2 or 3 years before I started tackling any of this.
Yeah.
Yeah.
Yeah, I don't have the answer to that. I think I go based on the individual's clinical skill set, the complexity of the case they're looking at. Yeah.
Cool.
Let me get you a more clear answer next time we meet.
Sounds good.
Yeah.
All right, guys. See y'all later.
All right. Hey, next
Thank
Monday
you so
night,
much.
ENT. Bring your ENT questions. All right. Have a good night, everybody.